this webinar. So today's topic, as you all know, is on the hepatitis C virus, diagnostic approach and challenges. I felt prudent to bring up this topic in this scenario because in the context of COVID and other diseases, especially with the COVID pandemic, people have somehow forgotten about hepatitis C virus. But let me remind you all that hepatitis C virus is a global issue. There's a huge global burden of hepatitis C virus infections, most of which are chronic. And as my colleague has rightly said, every year lots of people die due to hepatitis C virus related liver diseases. So without wasting much time, I will try to bring you all an insight into the hepatitis C virus infection, its pathogenesis, its diagnostic approach, and the current treatment options available. So to begin with, hepatitis C is a positive stranded enveloped RNA virus belonging to the family Flaviviridae. In fact, it is the only member of the genus Hepaciphyllus in the Flaviviridae family. And as I have said, it is a major worldwide cause of chronic liver disease. So, as you all know, hepatitis C is a worldwide cause of chronic liver disease, and there's a huge global health burden of hepatitis C. So, among the types of hepatitis virus, we have hepatitis A, B, C, D, and E, of which hepatitis B, C, and D usually are transmitted parenterally, and hepatitis A and E, they usually follow the enteral route of transmission. As I have said, about 180 million people are infected with hepatitis C virus, and it accounts for about 3% of the global population. Annually, 3 to 4 million people become infected with this virus, and the important fact is that HCV prevalence exceeds HIV prevalence by roughly 5 times. So sometimes we forget about HCV, speaking only about HIV, but let me tell you that the prevalence of HCV exceeds HIV by 5 times. More than 3.5 to 5 lakh people die every year due to hepatitis C related end-stage liver disease. The worldwide seroprevalence is about 3%. The variation in distribution in North America is about 0.4 to 1.1%, whereas it is more than 10% in North Africa. It is responsible for 85% of cases associated with post-transfusional non-A, non-B hepatitis. Hepatitis C carrier state in India is around 1 to 2%, and around 15 million people are infected with this virus, and 20 to 30% of patients are responsible of HIV infection are presenting with chronic liver disease. Infection with hepatitis C virus remains chronic in 70 to 85% of infected individuals. In 20 to 40% cases, chronic hepatitis C infection causes end-stage liver disease like cirrhosis, hepatocellular carcinoma, liver failure about 20 to 30 years after hepatitis C virus infection. I will dwell into the details about why hepatitis C virus infection is mostly chronic in the later slides. If we talk about liver transplantation, then it has been seen that liver failure from chronic hepatitis C is one of the most common causes in patients requiring liver transplantation. If we speak about the age and sex preponderance, it has a slightly male predominance with the highest incidence between 20 to 39 years of age. If we see the HCV infection prevalence worldwide, you see that some countries in the North Africa, they are in the red zone where the prevalence is greater than 10%. India is in the yellow zone where it is between 1 to 2%. And there are countries like Canada, there are countries like the North America where the prevalence is lower. So if we see the infection of HCV in key populations, so people with IV drug abuse, they were found to be having 69% incidences of hepatitis C infection, followed by TB patients, 17% in patients like MSM group, that is men having sex with men, 11% in patients with STIs, and 10% in sex workers. There was a study which was conducted in Georgia to see the prevalence of hepatitis C and HIV co-infection. It was found that 49% of patients were HIV and HCV co-infected. It must be reminded that there is no prophylactic vaccine or specific immunoglobulin against hepatitis C, but there are effective antiviral treatments. Coming to the microbiology, it is spherical in shape and about 55 nanometer in diameter. The RNA genome, which is a single strand positive stranded RNA, it is 9.6 kilobase in length and has a single large open reading frame which codes for 10 proteins, of which 3 are structural, consisting of the core and the envelope proteins, and there are 7 non-structural proteins. There are 6 major genotypes and there are extensive quasi-species variation present in each infected individual. I will tell you about quasi-species in the later slides. So, as I have said, that hepatitis C virus particle consists of a core genetic material surrounded by a icosahedral protective shell of protein, which is further covered by a lipid envelope. So, there are 2 envelope glycoproteins, E1 and E2. If we see the genomic structure, the 5' end consists of a ribosomal entry site, and just adjacent to it are the genes which are coding for the structural proteins, that is the core protein C or the capsid protein, and the 2 structural envelope glycoproteins E1 and E2. So this is just a picture which is depicting the genome. This is the 5' end, this is the 3' end. These are the structural proteins and these in red are the non-structural proteins. So what are the non-structural proteins? They are denoted as NS for non-structural. So we have NS2, 3, 4A, 4B, 5A, 5B and a P7 protein which acts as the ion channel which is necessary for the efficient assembly and release of the HCV particles. Now it has to be noted that hepatitis C virus does not replicate via DNA intermediate. That is why it does not integrate into the host genome, unlike other viruses which do replicate via a DNA intermediate. The circulating concentration of the HCV tends to be relatively low, that is 10 to the power of 3 to the 10 to the power of 7 virions per ml. That is why visualization of 50 to 80 nanometer virus particles remains difficult. However, the replication rate remains high. It is about 10 to the power of 12 virions per day with half-life of 2.7 hours. This is just an electron micrographic picture of the hepatitis C virus. Coming to the structure, as I have said, so there's a core which consists of the viral RNA. Then there's this icosahedral protein covering, that is the envelope on which there are the envelope glycoproteins, that is E1 and E2. So coming about the genotypes, so there are 6 distinct genotypes and greater than 100 subtypes within the genotypes which have been identified by nucleotide sequencing. So if we look at the genotypes, so HCV 1 has 3, that is 1A, 1B, 1C. HCV 2 has 2A, 2B, 2C. 3 has 3A, 3B. Then there is 4, 5 and 6. So in total there are 6 major genotypes. And in each of these genotypes, there are multiple subtypes. If we see the global distribution of the genotypes, so here you can see that in India, 1 and 3 are mostly common. Globally, 1 is the most common, accounting for 70% to 75%. In the Western countries, 1 and 2 are more common. In India, genotype 1 and 3 are more common. Now, how is HCV transmitted? The most important route of HCV transmission is through infected blood or its products using non-sterile syringes, needles and medical instruments. Also during transplantation of infected donor organ or tissue, or occupational exposure with infected blood, including needle stick injuries. So this remains the most common mode of transmission of HCV. This also includes the cases where it is transmitted between intravenous drug users. Coming to sexual transmission, risk of sexual transmission of HCV is lower as compared to HIV and HPV. In monogamous partners, it is just about 2%. The risk is higher in patients who are having multiple sexual partners and in the MSM group. Coming to the vertical transmission, here again HCV is different from HPV. While the HPV chance of vertical transmission is about 20%, the chance of vertical transmission of HCV is 5 to 7%. The risk, however, is increased if the viral load in mother's blood is high. HCV is not transmitted by air droplets, vectors, or from animals. So, this is the chart showing the recommendations for HCV testing. This has been taken from the recent IDSA guidelines. So, one-time routine HCV testing opt-out is recommended for all individuals greater than 18 years of age. It should also be performed in persons less than 18 years of age who are associated with high-risk activities or are having high-risk exposure. So, high-risk activities would include IV drug use, the MSM group, the intranasal illicit drug use. High-risk exposure will include persons who are on long-time dialysis or have been on long-time hemodialysis, persons with having percutaneous or parental exposure in unregulated setting, healthcare, emergency, medical and public safety workers after needle stick, sharps or mucosal exposure to HCV infected blood, children born to HCV infected women, recipients of a prior transfusion or organ transplant, including persons who have received organ transplantation before 1992, blood transfusion before 1992, received clotting factor concentrates before 1967. These years are important because prior to those years, routine testing or routine screening for HCV before the blood donation or before the organ transplantation were not there. There are also other conditions where HCV testing is indicated, like patients with HIV infections, sexually active persons who are about to start pre-exposure prophylaxis for HIV, chronic liver disease patients or chronic hepatitis patients, including unexplained elevated ALT levels, as well as solid organ donor and solid organ recipient patients. Also, annual HCV testing is recommended for all persons who inject drugs, IV drug users, HIV infected MSM group, and also persons who are about to start pre-exposure prophylaxis for HIV. If we see about the follow-up testing and initial testing, then post the HCV antibody testing, HCV RNA-PCR testing is recommended to see the viral load and to see whether the infection is active or past infection. It is also indicated in persons with a negative HCV antibody test, but those who have been exposed to HCV within the prior 6 months. Also, it is to be done in persons who are at risk of reinfection after previous spontaneous or treatment-related viral clearance. Quantitative HCV RNA testing is also recommended prior to initiation of antiviral therapy to document the baseline level of viremia. Also, HCV genotype testing is to be considered in those in whom it may alter the treatment recommendations. I will come into the treatment in the later slides. Persons found to have positive HCV antibody test and negative HCV RNA PCR, it should be kept in mind that they are not protected from reinfection, but they do not have any evidence of current infection. Positive and CD4 positive lymphocytes in the portal, periportal and lobular areas in patients with HCV infection. So immune-mediated cell injury occurs due to the interaction of the HCV virus with the CD4 positive and CD8 plus lymphocytes. That is why we can see a lot of immunological diseases in patients with HCV, which are part of the extrahepatic manifestations supposed to be due to the circulating immune complexes, which include glomerulonephritis, mixed cryoglobulinemia, among others. The virus mainly replicates in the hepatocytes of the liver, and it is estimated that daily each infected cell produces approximately 50 billions. The virus may also replicate in the peripheral blood mononuclear cells. As I have said, the reason for them equating for the high level of immunological disorders in chronically infected HCV patients. Now, to see the mechanism of entry, to enter the host cell, the hepatitis C virus E2 and E1 proteins recognize and bond with the CD81 receptors present on the surface of hepatocytes and lymphocytes. That is why these two group of cells are the most vulnerable. After the interaction with the receptor, it enters through receptor-mediated endocytosis. In the cytoplasm, the mRNA undergoes translation, the polyproteins are processed, and the HCV RNA then replicates, after which new viral RNAs are packaged and transported to the surface of the host cell so that they can disseminate and complete a new cycle. So this is the picture. As you can see, the virus which is entering via receptor-mediated endocytosis, released into the cytoplasm, undergoing translation, followed by RNA replication, virion assembly, and finally transport and release. Now, coming to a most important concept, that why hepatitis C virus infection is predominantly chronic. Hepatitis C virus infection, it is different from the hepatitis B infection in the fact that the chance of chronicity in hepatitis C virus infection is more. Why is this so? This is because that hepatitis C virus undergoes rapid and permanent changes in its antigenic structure. So it has a high tendency to mutate, and at a particular point of time, several types of mutants are present together in a particular patient. So this group of hepatitis C virus having different antigenic structures undergoing repeated mutations are known as quasi-species. So they remain together as quasi-species. So the problem with this mutation is that due to this rapid and permanent changes in its antigenic structure, due to this rapid mutation, there are several quasi-species within a single patient. That is why it is very difficult for the host immune system to mount an effective immune response and eradicate the infection. That is why this hepatitis C virus infection tends to be persistent, tends to be chronic. As you can see, antigenic variability of the virus makes T and B lymphocytes unable to identify and respond to these permanently changed antigens. Now, if we see the antigenic structure, the envelope glycoprotein E2 is highly variable. Also, the non-structural 5B, which codes for the RNA polymerase, these are the two highly variable proteins, and they are prone to mutation. Also, the predominant antibody which is produced by the body is against the E2 part, the envelope glycoprotein E2 part. But as it is highly antigenically volatile, it is antigenically variable, that is why it is difficult for the body to mount an effective immune response. Also, the RNA polymerase, which is responsible for the RNA replication, that lacks the proofreading mechanism. That is why again there are generation of multiple mutants, and the replication without any proofreading mechanism makes it more liable to generate number of quasi-species. This is similar to the HIV, where again in HIV also at a particular time there are quasi-species which are present together in a single individual, and the reason is same. They are also, the polymerase enzyme lacks the proofreading ability, and due to this lack of proofreading ability, the error-prone replications are not corrected, and that is why at a particular point of time there are antigenically different quasi-species which are present together, and this is the reason why this infection tends to be persistent or tends to be chronic. So number of quasi-species reaches about 10 to the power of 10 to the 10 to the power of 11 per day. So if we see the timeline or the natural history of hepatitis C, so mostly in 75% cases, if the acute infection is usually asymptomatic, and the remaining, when it is symptomatic, Then also a major part is without any jaundice and the other part is with jaundice. If you see the timeline of acute HCV infection, only 15 to 40% undergo recovery and 60 to 85% proceed to persistent infection for the reasons which I have described earlier. Among these patients with persistent or chronic infection, 20 to 40% develop cirrhosis and 4 to 5% develop hepatocellular carcinoma, and these two account for the major part of the mortality and morbidity in hepatitis C virus infected patients. And as because in hepatitis C virus infection, this group, that is the persistent infection group, is more, that is why the chance of chronicity and thereby progression to cirrhosis and hepatocellular carcinoma is more. That is why hepatitis C infection is dreaded. Also, it must be noted that due to its antigenic variability and the development of causative species, it has been difficult till now to develop an effective vaccine similar to HIV. That is why it is a dreaded disease. So just to see the serologic pattern of acute HCV infection where the patient ultimately recovers. So first the HCV RNA appears. This is followed by the rise of the aminotransferase enzyme, and the anti-HCV antibody starts rising by about 4 to 5 weeks. If the patient recovers, then by 6 months the symptoms subsides, the HCV RNA becomes not detectable, and the patient is said to be recovered from the hepatitis C infection. Anti-HCV may persist for a variable period of time. If you see the serologic pattern for the acute HCV infection where it progresses to chronic infection, which is the majority of the case, we can see that even after 6 months, the HCV RNA still persists. There is fluctuating levels of the aminotransferase enzyme. Anti-HCV remains detectable throughout in the blood except in immunocompromised patients, and patient may have symptoms plus minus for a variable period of time. This is the most common pattern which is observed in HCV infection. In symptomatic patients, the symptoms are like other viral hepatitis like fatigue, fever, nausea, vomiting, abdominal pain, clay colored stool, loss of appetite, dark urine, and other constitutional symptoms. Incubation period is 6 to 12 weeks after exposure to the virus, and during this period, patient has no symptoms. Now, chronic hepatitis C. Chronic hepatitis C is a chronic infection which develops after 6 months from the acute phase of infection, as I have discussed. It is the main form of HCV infection, and it is chronic in 70 to 85% of infected individuals. It usually progresses slowly and is characterized by non-specific clinical symptoms. So coming to the diagnosis part mainly consists of the detection of the anti-HCV antibodies and the detection of HCV RNA. So if we see the timeline for the major tests which has been utilized or which have been used for the HCV diagnosis, first ELISA was used in 1984, followed by the advent of the Western blot or RIVA, which is obsolete nowadays, followed by quantitative and qualitative PCR. Genotyping came in 2003, real-time PCR technology in 2007, and 2010 we have the core region sequencing facility also available. Now coming to the serological diagnosis, that the detection of anti-HCV antibodies. So anti-HCV antibodies can be detected during the initial phase of elevated aminotransferase activity and also during chronic infection. So the different methods by which the anti-HCV antibodies can be detected are ICT, immunochromatography, dot and blot immunoassay, ELISA, CLIA, ECLIA, and ELFA. Immunochromatography test, as we all know, is a card-based test where the recombinant HCV antigens from the C, NS3, NS4, NS5 regions are used as capture materials and are coated onto the membrane of the test kit, where positive test is indicated by 2 lines, the control and the test line, and the negative test is indicated by only the control line. A slightly advanced version of this is the dot and blot immunoassay, and example being HCV Tridot or diagnosis HCV by dot by JMitra, where we see that recombinant HCV antigens from the C capsid region, core region, NS3, NS4, NS5 proteins are embedded in a test material in the form of two test drop, T1 and T2, whereas they are embedded in the form of one test dot T in case of diagnosis HCV by dot, whereas positive test is indicated by appearance of a colored reaction or the colored dot at C control region and either or both of the T1 or T2 region or the T region in case of HCV by dot. Coming to ELISA, which is widely used. Nowadays, we are using the HCV third generation ELISA like HCV, microELISA or QualELISA HCV third generation, where in third generation, we are also using the NS5 proteins for making the recombinant antigens. In the earlier generations, NS5 proteins were not used. So use of CE1 into NS3, NS4, NS5 proteins makes it more suitable for detection of all the 6 genotypes. We have the other test based on ELISA, that is the chemiluminescence immunoassay, also the electrochemiluminescence immunoassay by Roche, which use the double antigen sandwich immunoassay techniques. These tests are basically the extension of the manual ELISA platform. They are widely used because they are sensitive, they are accurate and give results within 18 to 20 minutes. Also, nowadays we are having the fluorescent immunoassay technique, also known as ELFA, and Vidas from Barmer utilizes this principle. Similar to ELISA it is, but then in ELISA the color reaction is detected, here the fluorescence is measured. That is the difference mainly. So what are the advantages of anti-HCV antibodies test? First, there is increased sensitivity and specificity. It is not influenced by HCV genotype. However, it has the disadvantage that it detects IgG antibodies. They do not discriminate between active infection or past infection, and they cannot differentiate between acute and chronic HCV infection. So if we come to the molecular testing, that is the gold standard. Detection of HCV RNA, it can be detected even before the elevation of aminotransferase activity in the phases of acute hepatitis C. So HCV RNA can be detected by bDNA analysis or the PCR or transcription mediated amplification. However, nowadays only the PCR is used, and PCR and TMA are more sensitive as compared to the branch DNA analysis. If we see the HCV PCR quantitative, there are two types of systems which are available. One are the open systems and are the closed systems like the CBNAT or the TrueNAT, which are becoming more and more popular nowadays because it is customized, tailor-made, and plug and play approaches there. In fact, in our hospital, we ourselves use the closed systems. There is another test technique, the HCV core antigen assay, which is not much popular, but nonetheless it has come into effect, that it is less sensitive than RT-PCR. However, it can be used as an alternative to HCV RNA for diagnosis of active or current infection and monitoring response to treatment. It is available nowadays in ELISA format, where we can detect the capsid antigen and the antibody to NS3 and NS4 antigen. So if we see the various phases of infection, so if the patient is having a prior cleared HCV infection, antibody test will be positive, viral load, that is HCV RNA, will be undetectable at 2 tests done 6 months apart. ALT may be normal, fluctuate or persistently raised. In acute HCV infection, then antibody will be negative because it becomes positive only after 5 to 6 weeks. The RNA is detectable in a very high level, and ALT test, that is aminotransferase, may be 7 to 10 times above normal. Chronic HCV infection, again antibody test will be positive, the viral load test will be detectable, and then there may be persistently normal, fluctuating or persistently raised aminotransferase levels. Nucleotide patterns, again, it is important because it is used in genotypic testing. By seeing the nucleotide pattern, we can determine the genotype, which is useful to determine the treatment or the outcome, because genotype 1b is more notorious for progressive liver disease, and it has a high propensity to progress to cirrhosis. If you see the treatment kinetics, there are two types, responders and non-responders. Responders may be having rapid virological response or early virological response, and non-responders might be null or partial responders. So in null responders, there is less than 2 log10 IU per ml reduction of the HCV RNA. In partial responders, there is greater than 2 log reduction, but it is not becoming undetectable by week 24. Rapid virological response most ideal, where the HCV RNA is undetectable within 4 weeks. Early virological response, where the HCV RNA reduction is greater than 2 log10, and HCV RNA is detectable is undetectable at 12 weeks, where it is known as the complete EVR. And HCV RNA undetectable at 48 weeks, it is the ETR, or the end treatment response. Now, the goal of treatment in HCV infection, this is important. What should be our goal? HCV infection treatment, the goal mainly is to prevent the development of complications, that is cirrhosis and HCC, achieve a sustainable viral response, which is defined as undetectable HCV RNA less than 15 IU per ml at the end of treatment. Now, if you see the treatment earlier, the mainstay of treatment was pegylated interferon alpha plus ribavirin, but this was associated with the high adverse effects and the moderate degree of viral clearance. Now, there has been the development of direct acting antiviral agents, or the DAA. With the use of DAA, they are now being the treatment of choice because they can produce SVR rate up to 90% with minimal side effects. Basically, 3 classes are available. One is NS5A inhibitor, NS5B inhibitor, and NS3,4A proteases inhibitors. Treatment regimen for HCV currently uses combination of different DAs with or without pegylated interferon and ribavirin. Earlier, all drugs used to be genotype specific, but now we have pan genotype drugs also. That is, which can be used in all genotypes. Duration usually is either 12 or 24 weeks, depending upon the HCV genotype and presence or absence of cirrhosis. So, if you see the different types of agents, so the NS5A inhibitors are mainly those which are ending with asbin. The NS5B polymerase inhibitor are ending with buvir, and NS3,4A protease inhibitor ending with brevir. So I will just show you the current treatment recommendations as per the IDSA guidelines. So if we see the current treatment guidelines, so mainly are divided into 2 parts. One is the treatment of patients, treatment naive adults without cirrhosis, and other patients with compensated cirrhosis. So if we see that for patients who are treatment naive adults without cirrhosis, we must do the FIB4 score, and it should be less than 3.25 to just ensure that there is no cirrhosis. Pre-treatment, we do some basic testing like AST, ALT, GFR, CBC, and the recommended regimens, if we see, is either glecaprevir or pibrentasivir for a duration of 8 weeks, or sofosbuvir or velpatasvir for a duration of 12 weeks. It is important that post the treatment, we need to see whether there has been SVR or not. So quantitative HCV RNA and hepatic function panel are recommended 12 weeks or later following the completion of therapy. If we see that in cases where there has been SVR, so follow-up is recommended in patients with ongoing risk of HCV infection. However, no liver-related follow-up is recommended for non-cirrhotic patients. If we see the treatment guidelines for patients with compensated cirrhosis, here we have to see whether the patients are not having decompensated cirrhosis. That is why we are doing the CTP score, and CTP score greater than equal to 7, those patients which we will exclude, because greater than equal to 7 CTP score means that the patients are having decompensated cirrhosis. Like in the previous cases, we will do some pre-treatment panels, pre-treatment tests, also HCV RNA viral load. Glecaprevir and pibrentasivir we can use in all genotypes, and if it is genotype 1, 2, 4, 5 or 6, that is not genotype 3, then we can use sofosbuvir or velpatasvir. Here, as because the patient is already having cirrhosis, so after the assessment of cure, that is whether the patient has achieved sustained virological response, we need to do surveillance by the ultrasound, seeing whether there is any progression of the cirrhosis. We can also we should also do the liver panels like the liver enzymes, and also to see whether the patient is progressing towards hepatocellular carcinoma or decompensated cirrhosis. So these in short are the main treatment guidelines for the hepatitis C virus infection. So to sum up, hepatitis C virus infection is, as you all know, is a chronic infection, and it is highly notorious for its chronicity. To prevent it, there must be a careful surveillance activity where, as I have said, that the test should be done in those groups in which it is indicated, like those who are the high risk groups and those during the blood donation, the solid organ transplant, all these groups, so that it can be detected at its earliest possible stage. Once detected, a proper follow-up and proper measurement of the hepatic enzymes, and also doing surveillance whether the patient is developing cirrhosis or not. These are all very important things. So thank you all. Thank you for patient listening. With this, I conclude my webinar. Thank you.
Dr. Patil, thank you very much. That was an extensive, set of informational slides that you presented today, and I believe you covered everything from A to Z. Thank you very much, sir. The time and effort that you've expended to bring forth this information to our attendees today, and we've had a very good set of attendees today. I'm sure if your explanation leaves nothing further for questioning. But I had a question, sir. You said we understand there is gold standard and there are other tests available in the country, but is there any, and you showed a certain testing algorithms as well, but what do you think is the future of HCV in India in terms of how do we go, where do we go from here? Because it's not been on the government's priority list, and like you have an algorithm, but not every algorithm is applicable, especially testing algorithms. What is applicable in the West may not be applicable in India. What is it that you recommend, sir?
So I think that as you have rightly said, that HCV is not in the government's priority list. HIV is the only government priority list, but then the thing is that, as I have said, that HCV is also equally important, if not more. So for me, the suggestion would be to have a high degree of suspicion, and likewise in HIV, where the government is focusing on sentinel surveillance and all those sorts of activities, HCV should also be included in that parameter. There should be sentinel surveillance, there should be regular surveillance, particularly in the high risk group, so that it can be detected at the earliest possible stage. Because nowadays what is happening, that all these surveillance activities are focusing mainly on the high risk groups who are at high risk for developing HIV. But then, as I showed in one slide, that HIV and HCV co-infection exists in 49.5% cases. So that is why I would suggest that similar strong surveillance activities should be focused against HCV also.
Right, sir. There was one question that came in from the audience about having a, if somebody is HCV reactive, should they be planning children? Because the high risk of transmission that exists.
So regarding vertical transmission of HCV, first of all, if anti-HCV antibody is positive, first the patient needs to be worked up, because anti-HCV antibody may be positive in a patient who has been cleared of the infection. So as I've said in one of the slides, we do a HCV RNA test. So HCV RNA test, if it is positive, it means active infection. Then it should be, if the patient is having active HCV infection, then the patient should be properly counseled regarding having children, because one, vertical transmission, which is less in case of HCV that's compared to HBV, but there is another thing also which is more important. Most of the HCV drugs which are used, they are contraindicated in pregnancy. So that is why they should be counseled that as long as the treatment continues till SVR is achieved, the couple should refrain from having children. On the other hand, if the HCV RNA quantitative is negative, that means the person is not having any active infection, then the couple should be having the person should be advised the HCV RNA quantitative test 6 months apart. So 2 negative HCV RNA quantitative tests 6 months apart indicates that the person has been cleared of any previous infection which might have happened, and the person is not having any active infection. So they may well go ahead for the planning of children.
Right. Thank you, sir. That is a very useful answer, I guess. A lot of people have doubts, but they are afraid of what to ask out here. One more question that came in from another medical practitioner, Dr. Sharma, was, sir, we have observed sudden increase in HCV cases in dialysis patients in our hospitals. What are your views on that, sir? What is possibly the cause for that, sir?
Yes, this is a very common problem, and that is why in the guidelines for HCV testing, so what is followed is that every 3 months the viral marker serology is advised for patients on hemodialysis. So here the problem is that the lot of the centers in which the dialysis is done, they have to follow this strict 3-month regimen. Next thing is that even after following this strict 3-month regimen, that is the every 3 months we are doing the anti-HCV antibody test, sometimes patients do turn out to be HCV positive. So there are reasons for that. Suppose a patient is HCV infected, but then 5 weeks has not yet passed since the entry of the virus into the host body. So within the 5 weeks, the anti-HCV antibody will remain negative, but the HCV RNA will remain positive. So in my advice, in the case of hepatitis C virus, it is prudent that this serology pattern is followed, and in those cases where a person suppose is coming to the center after having performed dialysis at another center, in those cases, in my opinion, rather than anti-HCV antibody, HCV RNA viral load should be done just to rule out any infection which must be harboring in the phase where the anti-HCV antibody is negative. So this is the main reason for which the cases in dialysis occurs. Persons might have done dialysis in some other centers where he might have become infected, and then coming to your center, you are doing the anti-HCV antibody, but then might be such that the person is within that 5 to 6 weeks window when the anti-HCV antibody is negative, but the person is actually harboring HCV. So these are the cases which might lead to the other patients turning out as positive. So in my opinion, one is that you do the HCV RNA quantitative RNA. Next, in those patients who are coming to your center after having done dialysis from some other center, also for the patients who are starting dialysis with you for the first time, they are also, you need to do an HCV RNA quantitative. It's my suggestion. The guidelines does not say HCV RNA quantitative. It says anti-HCV antibody only. Next is that proper cleaning and disinfection of the machine. This is again an important part. Dialysis machines, as we know, that on the same machine there are various patients which are undergoing dialysis. So one thing is that for positive cases, everywhere there are ER machines where only the patients which are seropositive patients like hepatitis C virus positive patients, for them the machines are separate. They are segregated from the other machines. First is to segregate the machines. Next, even for the other machines and all machines, the routine cleaning and disinfection. If we speak about the dialysis disinfection, so dialysis machines have got a hot disinfection and cold disinfection cycle. All these cycles need to be followed, and the proper cleaning and disinfection needs to be done so as to prevent the further transmission.
Thank you, sir. One last question before we end for the day. This has come from somebody who is I'm sure he's a person working in that medical diagnostics. Is in case of treated cases in HCV, the results are mismatched with rapid test results. and these are also not correlating with test results on other platforms. So there is a general sense of dissonance in terms of understanding that is that because the person is treated for HCV, his results may come positive on one, negative on another. What is the outlook that any diagnostician should follow, sir?
So as I said, in case of the rapid test, like the rapid immunochromatography test, so they are the most erroneous, and they are very error prone because there might be subjective variations and there might be false positives and false negatives also. So that is why if you see that in the guidelines for the national guidelines for testing, which are issued by NACO and which are done in blood banks also. So rapid tests are discouraged. It's only the third generation ELISA which is taken into account. So in my opinion, rapid tests should not be relied on. ELISA or ELISA based tests should be relied upon. That is either ELISA or the CLIA or the ECLIA or the ELPA. So these are more accurate than the rapid card test. So we have also seen in many cases the results of the rapid tests are not corroborating. So that is why in these cases, the ELISA based platform should be more relied upon.
Thank you very much, Dr. Palit. Thank you for your time and attention, sir, and for the very extensive information that you have presented today.
Thank you.
Thank you, everybody, and we wish you a very good weekend ahead. We'll see you very soon on our next webinar 2 weeks from now. Thank you.
Thank you. Thank you. Thank you.